Hi, my name is Dr. Marysia Tweet, and I am an associate professor at Mayo Clinic in Rochester and a practicing cardiologist here. And I'm very pleased to moderate this podcast series entitled The Intersection of Cardiovascular Disease and Female Reproductive Health. And today we are focusing on cardioobstetrics topic number 2 of 3, entitled Preconception Counseling for High-Risk Women. And I'm pleased to introduce our guest speakers today, our experts, Dr. Katie Young, who is a cardiologist at Mayo Clinic in Rochester, Minnesota. She has training in cardiac imaging as well, and she's the current cardiology director of our cardiovascular obstetrics clinic in Rochester. Dr. Carl Rose is a professor in maternal fetal medicine, and he has been at Mayo Clinic in Rochester since 2005 and has serves as the maternal fetal medicine fellowship director here since 2017. And I'm pleased that you both made the time to talk with me today about this very interesting topic. And you kindly participated in topic number 1, and I anticipate we'll also do topic number 3 together. But it is truly my pleasure. Many times we share complex patients, or I'm reaching out to you with questions. And so it's great to share some of the questions that I ask you when I'm caring for patients with our listeners today. So thank you for being here.
Glad to be here.
Yeah,
Fantastic. So this is a topic really focused on that high risk patient who comes in and she wants to get pregnant. So, if you have a woman coming in and she has known or even suspected cardiovascular disease and she says, I would like future children, and in some cases is already pregnant. I mean, what are the core components of the comprehensive evaluation, and kind of how do you decide what degree of testing patients need? And maybe Carl, you would go first, and then Katie, you can weigh in as well.
yeah. So speaking as an obstetrician, I would suggest we would typically start, depending upon the particular maternal condition, with a maternal echocardiogram, just to get a determination of maternal heart structure and function. Typically an ECG associated with that to look at rhythm. And if someone is coming preconceptually, there is not a perfect test, but many times doing exercise stress testing will give us an idea of their physiologic reserve. And again, not necessarily an absolute determinant of how they would tolerate a subsequent pregnancy from a cardiovascular perspective, but at least it gives us some objective measure. Katie, anything?
Yeah. No, so I agree. And I think this is, of course, a broad question. And when we think about all the patients we see, I think all of us can agree it's such a spectrum. So the plan is really going to have to be tailored, as Carl was saying, to the underlying condition, and what is needed will sometimes change. But first off, I would just highlight it's a team. So these patients, our cardiac patients going through pregnancy, really, we work together, and having that colleague in MFM and OB that you can call on and work with, I think is really important. And one of the, tenets of taking care of these basic tenets of taking care of these patients. But I agree, like when I'm seeing someone like, let's say, preconception or first trimester, obviously we're reviewing their underlying disease, but I totally agree with Carl. Echo, ECG, I do, update their basic labs, CBC, electrolytes, liver chemistries. I often do a baseline NT-proBNP as well. So I follow biomarkers, particularly in our cardiomyopathy or our valve patients. I find those useful, so that we know where they start and how we can trend those as another tool to help care for them. And if it's any aorta patient, so any kind of underlying aortopathy, having baseline cross-sectional imaging is also just like a really important piece. So whether that's a CT or a MRA, having a baseline evaluation of where that aorta is also important. And yeah, I agree with Carl too. We use exercise testing, not in everyone, but again, probably in those higher risk patients, again, a lot of our valve, heart failure, cardiomyopathy patients, maybe arrhythmia patients, we use exercise treadmill testing with cardiopulmonary exercise testing to see how they do, get better objective information about how they're really doing before pregnancy.
Well, that's really helpful. Now, there are tools out there like the modified WHO classification, CARPREG II, even the Zahara score that people can use. Do you use these scores? Are they helpful to you? And do they affect your counseling of your patients?
We do, Marysia. We do. I think that they're useful to categorize patients into sort of ballpark ranges regarding what the anticipated cardiac complication rate is during pregnancy, so that they are aware, as we are, and certainly in our moms who are modified WHO class 3 or 4, in those situations we will really have some very significant discussions about what the implications of a pregnancy are if they're not pregnant, and recommend against it in patients with modified WHO class 4. But in addition to that, if they're already pregnant at that time, have discussions regarding sort of how the pregnancy would be managed.
Yeah, agree. We both use them, and I think documenting that. And I do think that it's helpful for the moms and for the patients. So when you can give them that kind of, these are estimates, right, of risks, but helping using that as a starting point to really give them those estimates and what potential risks there may be in a pregnancy. I do think that patients and not, I mean, I think it's helpful for them to better understand where they are. And I would encourage anyone in cardiology that sees some of these patients or counsels patients to just review the update to the ESC document, the pregnancy cardiovascular disease management document that was just released last year, because they really expanded the modified WHO, and really helped better categorize where women should fall for various, congenital and acquired conditions. So it's much expanded, and I think it's extremely helpful for anyone that may be counseling these patients. So it's
that
resources.
That document you're referring to is the European Society of Cardiology
Yep.
consensus statement on managing cardiovascular disease with pregnancy. And that was just published in 2025 here, right? So it's
Yep.
a
Just
hot off
updated.
the press. Okay,
Yep.
that's excellent.
Yep. Great resource.
Fantastic. Carl, you mentioned this, so I'm just going to ask you this question now. And Katie, I'd be interested in your thoughts too. Are there any cardiac conditions where you would strongly or absolutely advise against any pregnancy? And I can imagine this is a very sensitive and difficult conversation to have with some patients. So how also do you approach that conversation in some of those patients where you feel very strongly that pregnancy should not be pursued? What are your
Yeah.
thoughts?
Well, you're right. They are challenging conversations, Marysia. Particularly as someone doesn't find their way to see us in a situation where they're not interested in having a family. I would say probably scenarios of maternal pulmonary hypertension, Eisenmenger syndrome, cardiomyopathies with ejection fractions less than 30%, someone with severe symptomatic aortic stenosis, someone with a dilated aorta, with the absolute number to be contingent upon what their underlying condition is. These are situations that I would say that we see, that really we recommend against pregnancy. I also mentioned to these parents, though, that the option of a gestational carrier, if that's acceptable to them, so they can biologically have a child that is related to them. And in addition to that, if they decide to proceed with pregnancy in any event, I always reassure them that we will be there for them. We will do our utmost to take the absolute best care of them, but we're not sure sort of how the pregnancy will go. And that's for both mom and for baby.
Yeah, I agree. I mean, I agree with what Carl says. And this is never easy. And I mean, it can be even preconception, needing to tell someone we don't think it's safe, or, if they're already pregnant, that's of course can be just very challenging. And it's just hard. It's hard for the patients, and that's really challenging. But I think it helps to approach it and just being very open and kind, and just you help give out that information to them and what you're concerned about. And I 100% agree with Carl, but then with his comment of just letting them know that we'll support them in their choices, right? And, this is my concern. This is my recommendation. If they maybe take the higher risk path or, maybe opt not to terminate or they become pregnant anyway, we care for them. We do the best we can to have the best outcome we can.
And for some of those patients that you mentioned, like the severe symptomatic aortic stenosis, or someone maybe with like Marfan and a dilated aorta, Katie, are these things that sometimes can be addressed before pregnancy, or even someone with cardiomyopathy low EF? Like, how do you approach that where they might be modifiable?
Yeah, so I think the structural things, so valve conditions, aortopathies. So certainly there are patients where we can lessen their risk and kind of take them out of that high risk category by them having their operation, and then certainly reconsidering pregnancy after that. So that of course moves that timeline of pregnancy much down the line, but for some that does make it safer for them to have a pregnancy. Some of the other, the cardiomyopathies can be a little harder. Only I say that because a lot of the medicines we use to help support a weak heart and the guideline directed medical therapy, many of those agents we can't use in pregnancy. So that becomes a little more of a nuanced discussion because it somewhat depends on how the ventricle responds to being taken off medicines and this, so that's a little bit more of a nuanced question. But Marysia, you're right. I mean, there are patients where we can improve things or optimize things with an operation, ideally prior to surgery or prior to pregnancy, to help make their risk more acceptable for pregnancy.
Excellent. You mentioned cardiac medications. So let's talk about that. What medications do we need to consider stopping? Which medications do you tell a woman, if you're thinking about becoming pregnant or going to start trying, stop now? Or are there medications that you wait till you find out that they're pregnant to stop? I mean, I'd be curious on your thoughts.
Yeah.
I can take some of that, at least as an obstetrician perspective. In our cardiac patients, warfarin use is not uncommon, particularly with mechanical valves. And warfarin appears to be teratogenic weeks, primarily 6 through 9 of the pregnancy, which unfortunately is literally at the threshold, usually when one discovers that one is pregnant. What I mentioned to those moms is that typically they need to be very vigilant about pregnancy testing. And optimally, we would discontinue warfarin by 6 weeks gestation. Say in a patient with a mechanical valve, we at that point in time would put them on an injectable anticoagulant, used typically enoxaparin, follow peak and trough levels up through about 12 weeks gestation when the teratogenic window, if you will, closes, and then we would transition back to warfarin for the remainder of the pregnancy. Other medicines that come to mind, as we mentioned earlier, the ACE inhibitor antihypertensives, the ARBs, the angiotensin receptor blockers, those are probably the most common others that we see. Sometimes when we talk about medication use during pregnancy, if it's something that has some degree of risk from a fetal perspective, but it is essential for from a maternal perspective, we will continue during pregnancy recognizing that, given that commonly the risk to a baby is relatively low, and at the same time, the risk of not treating a mom may exceed that.
Katie, thoughts?
Yeah, those are the big ones. So just a couple comments on warfarin. So again, that can be also a very nuanced discussion with patients and, with MFM and cardiology. So again, I think the take home to remember with warfarin is if it's 5 milligrams a day or more, then they cannot remain on it the first trimester, meaning they have to go to low molecular weight heparin. If their dose is less than 5 milligrams per day, in theory, you could offer them to stay on warfarin through the through the pregnancy, though the risk to fetus is not zero. So again, warfarin crosses the placenta. So if mom is anticoagulated, the baby is anticoagulated. So that's where that risk comes. Whereas with your low molecular weight heparin, it does not cross the placenta. So there's not that same fetal risk. And as Carl said, we can absolutely transition back to warfarin in the second or third trimester. I think practically what I think we see most is that women end up staying on low molecular weight heparin through their whole pregnancy. I think more often than not, that is what women choose after going through the various risks. I think that's what we see most commonly in our practice. And I think even a lot of our women, our patients will transition to low molecular weight heparin even when they're trying to conceive. So some make that transition, as Carl said, at the time of conception, but I think we have a lot of patients that actually make that transition earlier to low molecular weight heparin. And just remember that we have to do anti-10A monitoring. Weight-based dosing is not sufficient for pregnancy. It's a starting point, but then we need to check those anti-10A levels. And of course, that becomes most important when there's a mechanical valve. That's when these patients are very, very closely monitored with anti-10A monitoring. So ideally these patients talk to their cardiologist and MFM and obstetrician before a pregnancy so that a plan is really laid out and they have that opportunity to discuss all those options. And then the other big ones are, the ACE inhibitors, ARBs, and your ARNIs. So Entresto also cannot be continued in pregnancy. SGLT2 inhibitors, there's no safety data, so those have to be discontinued before pregnancy. And then even spironolactone also is withdrawn during pregnancy as well. So as you can see, when we look at our GDMT for someone with heart failure, that's 3 of the 4 medications. So that's where those patients really need a plan and close monitoring through pregnancy. If you're needing to withdraw some of their medical therapy, that's a complex patient that needs a lot of monitoring and counseling. And just a comment that we consider beta blockers safe in pregnancy. So really, we've used any of our cardioprotective ones, metoprolol we use most commonly, but carvedilol, bisoprolol. We have some patients on nadolol, propranolol. We do continue beta blockers throughout pregnancy. The main one we don't use and you should not use is atenolol. But I don't think we really use that a lot in more modern cardiology anyway, but that's the one to avoid. The others we do use in pregnancy and continue.
So I care for a lot of patients with young MI, both SCAD, but also atherosclerotic disease. And as you both are aware, we won't go into the SCAD topic, but there's a lot of controversy about pregnancy because it's associated with pregnancy. But when I think about my patients with myocardial infarction, maybe Katie, you want to answer this, but then Carol, I'm interested in your thoughts too. What do you advise about statins or dual antiplatelet therapy? Or I commonly tell my patients who've had a myocardial infarction and are thinking about pregnancy to wait at least 1 year. But any additional thoughts to add to that?
I agree with the timeline you suggested. I think there needs to be some time from the event and, a reevaluation with the cardiology team. Aspirin is safe. So, baby aspirin in pregnancy is safe. Clopidogrel, I think, or Plavix is a case-by-case type of situation. If the event is remote and it's not needed, we would usually not have a patient on that. But if, this is something that happened in pregnancy and it's a more acute, that certainly we would use it. Statins is evolving, but I would say we generally stop them. We do that. Our practice is currently, we hold those during pregnancy, and they're also not compatible with breastfeeding. So they're also held during that time frame. Carl, do you have any other thoughts?
Yeah, no, I'd agree. I agree with you there, Katie. Clopidogrel in general, I would say complete agreement, case by case basis. Usually, we will stop clopidogrel by about 36 weeks because our anesthesiology colleagues usually want moms to be off it for at least 7 days before they're considered a candidate for an epidural or spinal anesthetic, sort of during delivery. And the question on the statin is an interesting one. As we touched on previously, it's something that traditionally we have not used during pregnancy due to concerns for teratogenicity. Not sure that's really been borne out. There is some preliminary data that's come out regarding prevention of preeclampsia when started in the second trimester in patients who are high risk for preeclampsia. We're not using that clinically currently in our practice, but I think that is an evolving topic.
Excellent. And then any thoughts or comments on high-risk patients when they become pregnant, structuring the cardiovascular surveillance, fetal echocardiography. I think a lot of people have seen in the literature this concept of a pregnancy heart team. Comments on that?
Yeah, that's to say we are components of that. Generally, when someone conceives, we would get a baseline cardiovascular evaluation with help from Katie. And in addition to that, from an OB perspective, we would commonly do an early ultrasound to establish due date, determine how many babies there are, and usually serial ultrasounds through the second half of the pregnancy to monitor growth. Usually, depending upon the individual maternal condition, and I would completely defer to you, Katie, on this, we will do serial maternal echocardiograms every trimester. We will do a fetal echocardiogram if the maternal condition is heritable to a baby, and overall that risk is generally in the neighborhood of about 6% for many things. Some a little more, some a little less. And then usually what we have done here is typically around 32 to 34 weeks, as a group, we have met to discuss deliveries of upcoming patients with complex medical histories. And that includes myself and MFM, or one of my colleagues, Dr. Young, our anesthesiology colleagues, our labor and delivery colleagues, just so that way we can, if you will, construct a plan for the delivery of that patient in advance of that actually happening, along with some contingencies as required.
And, we will talk more about, labor and delivery and the pregnancy heart team in our topic 3, at which time both of you will join me again, along with Dr. Katie Arndt, who is one of our anesthesiologists here at Mayo Clinic. But one final question that we'll talk about then, so we can just touch upon it lightly, but preference for vaginal delivery versus C-section, in a patient with cardiovascular disease. Is there a preference?
Generally, we aim for vaginal deliveries if at all possible, Marysia. There's not necessarily a benefit to cesarean section in terms of maternal outcomes. The cardiac output's going to increase irrespective of method of delivery, either perhaps a little slower in moms who undergo labor versus moms who don't and have a cesarean. I think the only situations where we probably opt more for a primary cesarean section is if there's a lot of concurrent resources required for optimizing maternal care, peripartum or postpartum. And those might be our moms with pulmonary hypertension, perhaps our moms with mechanical valves who were coordinating discontinuation and resumption of anticoagulation.
Okay. I would say the big cardiac reasons to remember would be if they're therapeutic on warfarin, they'll need to have a cesarean section. If they, weren't able to transition off, or, so if they're therapeutic on warfarin, and that's in part due to the risk to the fetus, from passing through the birth canal through a vaginal delivery. And then really, for cardiac things, so just be, if mom is unstable. So if a couple things would be, decompensated heart failure, really significant, valve stenosis was symptomatic, or maybe someone with an aortopathy that's had some growth or is a little unstable or has a large diameter of the aorta. Those would be reasons a C-section may be performed. But for many of our patients, most of the patients, we would say vaginal delivery is preferred for almost all of our cardiac patients. And then, of course, obstetric reasons happen too. So, yep. So that happens also. Yep.
This has been incredibly informative. I have learned a lot. I just always love talking with both of you. I think whenever I speak with each of you about patients or just topics in general, I learn something new. So again, I thank you for your time. Any final imparting words for our listeners? And of course, I look forward to talking more about the actual pregnancy, labor and delivery, and postpartum care in women with cardiovascular disease in our topic 3. But any imparting words before we sign off today?
I would say sort of particularly for our moms who have very high risk cardiac conditions, always best to try and determine sort of candidacy for pregnancy prior to conception.
Yeah. Preconception counseling, I think, is super important, and really an advocate for that for our cardiac patients. And I think just having a team. This is hard to do alone. So I think wherever you are, really helping to develop your team of colleagues that you can call on, as we all do here. So we all work together very closely and often need help. And so this is, I think, having that team is super important. So I hope many listening that take care of these women are able to kind of have that and develop that where they are as well.
Fantastic. Thank you again. I hope you have a great day. Take care.
Yep. Thank you.
Thank you.
At Mayo Clinic, learning fuels world-class care. I'm Dr. Peter Noseworthy, Chair of the Division of Cardiac Electrophysiology. I hope you enjoyed today's episode, and I want to let you know about the full courses that we have available. Head over to cveducation.mayo.edu and explore our live and online programs, quick on-demand modules, and CME accredited masterclasses. Join the thousands of clinicians who have already turned their curiosity into expertise at cveducation.mayo.edu.